My name is Professor Hans van der Wal. I'm a nuclear medicine physician in Sydney, Australia. I would like to introduce you to a new test that has been developed for the unusual symptoms of gastroesophageal reflux disease. Now, we developed and patented the test, and I would like to show you some of the papers we've written to validate the test against the current standards of endoscopy and pH and impedance testing. Now, the reason we developed this test was the inability of the current reference standards like endoscopy and pH impedance to answer unusual or what is called atypical symptoms of reflux. And these are classically troubling or chronic cough, recurrent sore throats, constant throat clearing, which often is complained about by your partner or your relatives, postnasal drip, recurrent sinusitis, especially after you've had sinus surgery, recurrent ear blockage and pain, and more importantly, recurrent chest infections that can damage your lungs. Now, the two standard tests we talk about are endoscopy and pH impedance and manometry. Now, let's start with endoscopy. Now, endoscopy has a number of issues with it. Firstly, it can only tell you what's going on in the esophagus. It is expensive, it's invasive, and the yield in the literature for the diagnosis of reflux disease is approximately 30%. The reason that it doesn't pick anything up is because of the use and the overuse of really powerful drugs like the proton pump inhibitors, or PPIs as we call them, that stop the effect of acid on the esophagus. So normally in 70% of cases you see a normal lower esophagus, which you do here in the left panel, but in a small proportion, about 30%, you'll see evidence of acid and other agents from the stomach and bile creating injury to the lower part of the esophagus. This is often called esophagitis, or if it's very advanced, it's called Barrett's esophagus. The next thing I'd like to talk about is the use of 24-hour pH and impedance. Now, this is accepted as the reference standard for diagnosing reflux disease in the esophagus itself. Now, in this diagram, what this entails is putting in a catheter through your nose, down through the back of your throat, into the esophagus and down into the stomach. There are two sets of electrodes that span from your upper esophagus into the stomach, one of which tells us about the acidity of the fluid that's in the reflux that comes up. The second is impedance, which tells us something about the electrical changes induced by the fluid being in the esophagus from the reflux. Now, one of the big problems here is that regardless of what you're on, as acidic fluid rises in the esophagus, it is partly neutralized by swallowed saliva, which contains bicarbonate, and by the time it reaches the upper esophagus, it's got low acidity, or often it may be neutral. It is invasive to do this because you have to have this catheter in for 24 hours. It's expensive, and some people just don't tolerate having this in the nose and throat. But nevertheless, it is considered the reference standard. Now, what are the advantages of the new test that has been developed? Firstly, it's simple, it's non-invasive. You get a rapid result the same day. It's bulk billed in Australia. It uses a small amount of radioactivity with a technetium label on it, and that has a half-life of approximately 6 hours. You don't need any needles, and there's no real invasive technique used on you. Now, what is the preparation for the test? It's again very simple. You fast for 4 hours. You may take your anti-acid tablets, whatever they may be, the PPIs, ranitidine, Zantac as they call it, or Mylanta, up to the 4-hour period. What you do is you drink 50 mils of water with a small dose of the technetium agent in it. You then swallow another 50 mils of plain water. You stand in front of the gamma camera that detects what's happening with the radioactivity in your stomach for approximately 2 minutes. You then lie underneath the camera for 30 minutes in the supine position. Following that, you go away for approximately 90 minutes. You're not allowed to eat or drink anything in that 90 minutes. When you return, we do what we call a SPECT CT. Firstly, the gamma camera goes around you and takes a record of the counts in your head, neck, and lungs. You then go further into the ring for a CT study, which is a low-dose CT. We fuse the images, and we can then show you where reflux ends up in the head, neck, and lungs directly in the imaging. Now, this has a very low radiation dose for it. Because we use radiation, you need a referral from your doctor, be that a specialist or a GP. This is the first stage where you lie underneath the gamma camera. These 3 images form a cine loop that shows us what's happening in the stomach in the white here. Shows you reflux going up into the esophagus, and what we can do is quantify your gastric emptying, so we know the half-life of how long the fluid is in your stomach. It can tell us the frequency and amplitude of the reflux and whether it sticks to the esophageal tissues over that 30 minutes. But the most important part of the test is the SPECT-CT that I described earlier. And in these 3 images, it shows you the kind of things we can diagnose. For example, in the first panel here, it shows you reflux in the voice box itself. It's in the oropharynx, or in your mouth. It can go up into your maxillary sinuses. And here, again, you see it in the left maxillary sinus, and then coming down the eustachian tube into your middle ear. And rarely it goes up in through your tear ducts or the nasolacrimal system, and we visualize it in the eye itself. Just as importantly, we examine the lungs for evidence of reflux microaspiration. In the upper panel, I show you a preoperative study where there is reflux in the left lung, which is shown by the red arrows here. In the second panel, I show you what happens after anti-reflux surgery, which stops the microaspiration, so you no longer see evidence of aspiration into the lungs. How do we know all this is real? Well, we do something else with this study. We also put a oxygen saturation monitor on one of your fingers, which measures the entire 30 minutes of oxygen saturation. We also analyze what's happening in your voice box, and in this image here you can see where the pink line is. Wherever it crosses, the pink line indicates an episode of reflux has reached your voice box. In this case, it's 5 episodes in the 30 minutes. In the lower panel with the oxygen saturation drops from 99% to 91% as a result of tracer or microaspiration entering your lungs or airways. If you are interested, you can get more information from these two websites. That's refluxtesting.com or cnimaging.com.au for more information. Thank you for listening.